Let's continue with thoracic imaging on to part 2, lung pathology. I'd like to take the next couple of slides to discuss lobar anatomy. Then we'll move into cases looking at chronic lung conditions, acute processes involving the thorax, and malignancy. Here we have a frontal and lateral view of the chest. We can see in the right lung there are 3 lobes defined by the major and minor fissures, right upper lobe, middle lobe, and the right lower lobe. In the left lung there are 2 lobes, an upper and a lower, and a lingular segment which is part of the left upper lobe. We can see that the lingula corresponds to the middle lobe equivalent. Silhouette sign is a principle based on identifying things of different attenuation on radiography. We are unable to differentiate different substances if they have the same density on X-ray. This helps determine the location of abnormalities within the lung. So an example of silhouette side here, we have a frontal view of the chest. We can see that there's an opacity within the right lower lobe, which obscures the right heart border. Here we see on a cross-sectional imaging of the chest, this is CT, contrast was given. We can see opacification there. We have a consolidative opacity within the middle lobe. We see air bronchograms corresponding to this abnormality on the radiograph. This is an example of silhouette sign. Another dense consolidation, this time in the right upper lobe, obscuring the mediastinal contours. So on the next few examples, let's just identify the lobe in which the abnormality is occurring. Here we have a frontal radiograph. We can see that there's an abnormal nodular density in the left upper lobe. Where's the abnormality on this frontal view of the chest? We can see a opacity here in the right upper lobe. One thing to take note, the minor fissure is retracted up and there's associated volume loss. So this is atelectasis / consolidation of the right upper lobe. Abnormality on this 2-view chest. We can see this ill-defined opacity, which obscures the left heart border. A little bit more difficult to see on the lateral view, but this is within the lingula. Where's the abnormality? On the frontal view, somewhat difficult to see, but very clearly seen on the lateral view that we have abnormal opacification within the middle lobe. When discussing opacities within the lung, they can fall into different general categories. The first one being airspace disease, when there's abnormal filling of the alveoli. We can have interstitial opacities where there is a process that's centered within the interstitium or the scaffolding or supporting structures of the lung, and then atelectasis, which are opacities that are created due to the alveoli collapsing, creating opacities as well as associated volume loss. So nice example of both alveolar and interstitial opacities. So looking at this first image, we can see that there's this patchy, fluffy cloud-like opacity within the right upper lobe. This is an example of alveolar opacities, as opposed to this patient who has underlying pulmonary fibrosis, and we see this very coarse, linear type opacities within the bilateral lungs. This is thickening within the interstitium. So nice example of interstitial opacities in a patient with pulmonary fibrosis. Moving on to cases. 56-year-old female with shortness of breath. So underlying emphysema, which you probably recognized, lungs are hyperexpanded and lucent. There's associated flattening of the diaphragms and increasing AP diameter on the lateral view, which is going to correspond to barrel chest on physical exam. Central lobular and paraseptal emphysema are terms that you may see particularly in radiology reports. So I'd just like to share a couple of examples. Central lobular emphysema is going to be within the substance of the lung, and we can see that there's these scattered lucencies within the lung parenchyma, almost a Swiss cheese type appearance. That's an example of central lobular emphysema. Paraseptal emphysema occurs within the periphery of the lung, and you get these peripheral cystic changes demonstrated here by the red arrow. Bullae can occur. You can see nicely on this frontal view of the chest that you have this very round circumscribed lucency within the right upper lobe. On first glance, you may worry about pneumothorax. We don't see lung markings. You may mistake this. Is this a pleural line? But nicely depicted here on the CT that we can just see that this is a clearly defined bullae within the right upper lobe. Next case, 64-year-old male with progressive dyspnea and dry cough. We have a frontal view of the chest as well as CT of the chest taken at the base. And this is an example of interstitial lung disease, actually this case that we saw earlier when looking at interstitial opacities. So this is an example of pulmonary fibrosis, which occurs when there's scarring within the interstitium of the lung. This can be idiopathic or be a result of prior insult. We can see on the CT images that this has a lot of the features that we look for when evaluating pulmonary fibrosis. We see that there's interstitial thickening. There's also architectural distortion within the lung. Some of these peripheral cystic structures correspond to honeycombing, and we can see a nice example of traction bronchiectasis where the airways abnormally dilate. 43-year-old male with chronic disease and new fever. So this demonstrates chronic findings of cystic fibrosis. It is slightly upper lobe predominant. We see bronchial wall thickening, bronchiectasis, and if you were very astute, you would see that there is this cystic area within the right mid-lung with an air fluid level. So this is fluid within a dilated airway, suggesting superimposed infection. Anytime you see an air fluid level within the lung, we're worried that there could be a superimposed infection, either within a dilated airway, like in this case, or in a pulmonary abscess or pre-existing cavity. 34-year-old homeless male with cough. So left upper lobe, airspace opacity. In this case, this was tuberculosis. Tuberculosis can have varied appearance on imaging, depending on whether it is primary or post-primary infection, and whether or not the patient is a child, an adult, immunocompromised, or immunocompetent. So primary infections can occur anywhere in the lung. In post-primary infections in adults, the upper lobes tend to be preferentially involved. Cavitation is also more commonly seen in post-primary infection. Infection from TB can spread through the blood and give a miliary pattern of TB. It can also spread through the airways and a bronchial spread of infection. 24-year-old male, new diagnosis of HIV and cough. Corresponding to the hazy opacity seen on the frontal view of the chest, we see bilateral ground glass airspace opacities, mid-lung predominant. This is an example of pneumocystis pneumonia. This only occurs in immunocompromised individuals, typically people that have CD4 counts less than 200. The principal imaging findings are bilateral ground glass opacities. There can be associated nematoceles or cystic changes within the lungs, as well as interstitial thickening. 24-year-old male patient with no past medical history, presenting with fever and cough. So we see this abnormal opacity on the frontal view. It obscures the left diaphragm, posterior on the lateral view. So we know that this is within the left lower lobe. So left lower lobe consolidative opacities with faint air bronchograms here. This is an example of a left lower lobe pneumonia. I'd just like to show you this case here. This is a rounded opacity overlying the left hilum on the frontal view. We can see that it projects posteriorly within the superior segment of the left lower lobe on the lateral view. This is a young patient. This ended up being a round pneumonia. However, in an adult patient, this will need to be followed to ensure that this completely resolves and exclude an underlying mass or malignancy. 33-year-old previously healthy male who's had cough for the last 2 weeks. So this is an example of atypical pneumonia. We see bilateral interstitial and airspace opacities. We can see some linear opacities corresponding to the thickening of the interstitium, and then these more cloud or ill-defined opacities which correspond to the alveolar opacities. This is an example of mycoplasma pneumonia. 78-year-old male with chest pain and dyspnea, as well as leg swelling. So this is an example of pulmonary edema. He's got all the findings to support that. Cardiomegaly. The pulmonary vasculature is enlarged and indistinct. There's bilateral interstitial opacities demarcated by these red arrows. These are the curly B lines that you commonly hear about in the setting of heart failure. And he also has some early alveolar opacities, which correspond to the pulmonary edema. 61-year-old male, smoker for the last 49 years, presenting with hemoptysis. So very difficult to see the abnormality on the radiographs. I'll just give you a second to look at that, and then we'll move on to the CT. So here we have in the left upper lobe some ill-defined ground glass airspace opacities. So infection versus pulmonary hemorrhage, given that he had some underlying hemoptysis. Important to note that there's no underlying mass lesion in this case. So pulmonary hemorrhage can result from a variety of causes. Hemoptysis, remember, can be caused by malignancy, bronchitis, or other airway abnormalities. Bronchiectasis occasionally will produce hemoptysis, pneumonias, as well as vasculitis. You can have pulmonary hemorrhage without hemoptysis, which is important to keep in mind. 72-year-old female presenting with hemoptysis. Much different appearance of this radiograph. So we can see that there is this hazy opacity involving the left lung. On the lateral view, we have this anterior opacity with hyperexpansion and lucency of the left lower lobe. This is an example of left upper lobe collapse. And this is secondary to this large obstructing left hilar mass. So this is an example of an obstructing left hilar mass, which ended up being a primary pulmonary malignancy in this case. One thing to remember whenever you have a lobar collapse in an adult patient, we are going to be worried that there could be an underlying endobronchial lesion or underlying malignancy. 80-year-old male patient with weakness. Maybe a little bit of an eye test, the abnormalities within the left mid-lung. Here we see the nodule that we saw in the radiograph corresponding to this heterogeneous nodule within the left lower lobe. We can also see that there is a little bit of fullness within the left hilum. So this is an example of a primary lung cancer. Primary lung cancers are typically placed into two categories, whether it is a small cell or a non-small cell, often presenting as a single pulmonary mass or nodule. The margins may be spiculated or lobulated, and then we also want to look for evidence of metastatic disease, either within the thorax or distally. So in this case, there's a malignant metastatic left hilar lymph node, but metastasis can occur other places as well. I just would like to show you this case of a 72-year-old female who initially presented with cough and fever. This is her initial radiograph. We can see this fairly large opacity, predominantly central, overlying the right hilum within the mid-lung, also some parenchymal opacities within the right upper lobe. This is 6 months later, and the size of the opacity is not significantly changed, but it's more dense, maybe a little bit of increasing opacity within the right upper lobe. And here on the CT, we have a fairly large consolidative opacity with solid components as well as cystic areas, small layering of fusion dependently. This was an example of an adenocarcinoma. Here's a 60-year-old female with a history of pancreatic cancer. For follow-up, chest port, bilateral large pulmonary nodules. We can see the nodules nicely on this CT of the chest, taken at the level of the pulmonary artery. This is an example of pulmonary metastasis. So in pulmonary metastasis, we typically tend to see bilateral pulmonary nodules. They're often round and circumscribed, especially when there's a known malignancy. This pattern is consistent with pulmonary metastasis. Another example that I'd just like to show you, this is a 57-year-old female who was previously treated for a right-sided breast cancer a number of years ago when she was 45. We can see the clips within the right anterior chest wall as well as the right axilla from her prior lumpectomy and lymph node dissection. She presented with cough. This is her initial chest x-ray. We can see bilateral pulmonary nodules and this more dominant mass along the right lateral chest wall. Can also, if you look carefully, notice that there's destructive changes of the associated rib. Here's the CT. We see this soft tissue and partially calcified mass with associated destructive changes of the associated rib. See this nicely on the lung windows. And then the bilateral pulmonary nodule, some of which have associated calcification. This was an osteosarcoma of the right chest wall with pulmonary metastasis. And I just wanted to show this case as an example. We commonly see calcified nodules in the lungs. However, there are some malignancies which will demonstrate calcification, osteosarcoma being one, as you know, given that it's a from the bone, actually has osteoid matrix associated with it that gives you this calcification we can see here.